Okay, I was going to suggest people stand up and get a little exercise, but after that it's too dangerous, so just stay where you are, okay? Don't anybody move. So I'll try and get through this quickly. We've all been sitting for quite a long time. My name is Mark Tyndall. I'm from the University of British Columbia in Vancouver, and I'm going to change a little bit of the pace. The title in the program is nothing to do with what I'm going to talk about today, but I will talk about prevention in a large scale, in a very, maybe a non-medical way around Hep C prevention that I've been working on. I have no conflicts to declare. This is probably the only important slide that I'll show. It's a Banksy street art, and I went to a museum just yesterday called MoCo, and they had some Banksy there. But keep your coins, I want change. So when we talk about people who are marginalized, a lot of people aren't that interested in getting hepatitis C treatment, and that's been my experience for the last 20 years. And you could, instead of saying keep your coins, you could say keep your hepatitis C medications. I really want change. And so when we're dealing with a large population, I think the reminder for me is that we can't just silo this and talk about treating one disease as though it's not related to the whole situation that people find themselves in. And my career really focuses on these 6 issues, and often as I've been studying these different areas, be it HIV or Hep C, homelessness, mental illness, sex work cohorts, and now the overdose epidemic, it's quite clear that we've tended to silo these things. So we've just trying to go from one to the other. There's whole meetings around these specific topics when at the end of the day, basically, the drivers of all these are basically the same, and often the population's the same. When I first went to Vancouver in the late 90s, I took over this cohort called Hepatitis, and people have been followed for a long time, and they continue to be followed for HIV. Over the last 6 or 8 years or 10 years, we've kind of did all the same analysis for HIV, only we have hepatitis C papers now. So and it turns out that all the drivers and associations and risk factors and determinants are basically the same thing. So and we could do the same analysis for any kind of outcome we want, whether it's homelessness or sex work or now overdose, that we have to be reminded that really the same population is affected, and many of the same drivers are what we need to be focusing on. One way to look at this is through the lens of structural violence, and my career in sort of epidemiology and research has really used determinants of health kind of language, but I found that now that's quite passive, that these aren't really things that just happen to people, but these are structures in place that push people to these high-risk situations. A definition of structural violence by Paul Farmer is structural violence is one way of describing social arrangements that put individuals and populations in harm's way. The arrangements are structural because they are embedded in the political and economic organization of our social world. They are violent because they cause injury to people. And what you can pick up from this is that a lot of the things that happen to people and the risks that people find themselves in are not just by chance, that we create policies, especially around drug policies, that really drive these epidemics and drive people into very risky situations. That can be encapsulated as far as hepatitis C and HIV risk on the war on drugs. And I think it's important that all of us involved in this field talk about these structural things. And although we feel helpless to do anything directly or immediate about it, I think we all have to recognize and keep pushing for policy changes that make all of our work in prevention much more difficult, because we're pushing uphill against forces that are really counterproductive to a lot of the work that we're doing. And this drives us into bad environments. So these are scenes around Vancouver, and somehow we tend to sort of blame people that are in these situations, and we're always trying to push people out of tent cities, and we're continuing to marginalize people, and police are chasing people down. But these are policies that we put in place. We're not supplying the right housing, the right social supports, and the right medical care that people actually need. And as a result, this is what's driving people. So these kind of environments that we push people to makes it very difficult for us to engage people and do the care that we want. And for the example of hepatitis C, clearly people in these situations are hard to engage, not because there's anything about them that they don't want to be cared for and treated, but we put in place policies that have driven people to the margins and, again, make our job as far as testing and treating people so much harder. As Michael was talking about involving the community, when you ask the community what they want, and I spend a lot of time working with community groups, it's not so much that these are signs and a protest from about overdoses and injustices in February of this year. But if you look at what people are calling out for, again, it's structural change. There's nothing on these banners and signs that says we need hepatitis C treatment or we need more HIV care. These are things that people are facing all the time. Prohibition, police brutality, red zoning, poverty in general. These are things that if you talk to the community, that's what they really need and that's what they really want. And if we can start to address some of these issues, it'll make all our medical interventions so much more doable. A lot of the work that people have been doing, first in HIV and then hepatitis C, has been totally sidetracked by the overdose epidemic, and it's really hit hard in North America especially, and this is some graphs from what's happened in British Columbia. And we tolerated 200 or 300 overdose deaths for a couple of decades, and then starting about 2014 or 2015, we noticed an increase, and in the last 3 years in the province of British Columbia, over 4,000 people have died of overdoses, and that happened because the illegal drug supply, which was heroin, switched to fentanyl, and people had a lot of trouble dosing this properly, and we've had just a terrible time with overdoses. And since overdoses is a acute life-threatening event for people, it's taken over a lot of the conversation from what was hepatitis C amongst this population. About, in a snapshot, about 80% are males, 80% are between the ages of 20 and 49, and most people die on their own. So 78% are found without any 911 calls or any intervention. And so this is what we've really focused on. Ironically, in many communities, these people have all died with their hepatitis C treated and an undetectable viral load. So just to really illustrate the fact that unless we take care of the whole issue, all the issues, just treating one infection at a time is probably not going to make a huge impact on people's health. What we've focused on, at least in British Columbia, is harm reduction. There's many things we've done as far as getting more naloxone out there. This insight started in 2003, and it was North America's first supervised injection site. And starting in 2016, we've opened up about another 30 throughout the province. So we went from 1 to about 30 in about a 3-year period. And they see a lot of people right in the downtown east side, the infamous place where there's a high concentration of drug users in Vancouver. There's 5 supervised sites now. So there's a lot of intervention to reverse overdoses once they happen, but we haven't been able to do much about what drugs people are using and the exposure that they have to that. And that's why we're now focusing more on trying to get people a safer supply of drugs. And I'll talk about that in a second. I've been talking about putting drugs in machines for a couple of years now, and we have one now. So this is a picture that I just took last Thursday, this machine was delivered called MySight, and I'm planning to fill it with hydromorphone pills that people can get. It's a biometric machine, so it reads the vein pattern in people's palm, and it identifies people, and you can program the machine to give out pills at any kind of schedule that you want that's appropriate. At the beginning, people would have to come 4 times a day to get their pills, but then as we can graduate people to pick them up less and less. Clearly giving out potentially deadly drugs is controversial, but we're at the point now where we need to do something to give people the option to not buy fentanyl and die of overdoses. Now, this technology is I think, fantastic and should be used for a lot of drugs and a lot of things that we do, including hepatitis C drugs. So you could put your 8 weeks of pills in this for people who live or marginally housed or live in a shopping cart who clearly it's not a great idea to give them all their pills at once and hope that they'll take them, that you could program this machine that they could come every day and get it, and in real time you could know who's got their drugs and what time they picked it up. So I think this has a lot of potential in our setting to get people on treatment and to follow people quite closely without the constant interaction with the healthcare system. And one of the things around the stigma that people have been talking about is that we really need to put people in position where they don't feel stigma, and that instead of waiting till we sort out stigma, I think giving people some autonomy and can pick up pills on their own is a way to just undermine that whole thing. And sometimes we think that, you know, having people go to a pharmacist every day to get their pills is a supportive, connecting thing to do, but for most people that is not what they want to do. So if we can offer people this kind of technology where they don't have to be confronted every day, I think it could be very useful, and we'll experiment with that. For whatever reason, I picked the very hardest thing to give out first with deadly drugs, but we could put non-deadly drugs in these things and test it out, and I think it would be quite successful. And the machine is also very cool in that there's a video screen there. There's a camera. It can be interactive. If people want to connect with somebody, we could set the machine up where they could have some face-to-face contact, or we could send messages to people through these machines. So I'm very excited about the whole using this kind of technology that we could set it up. You could come up with whole programs and templates where you could take it to more rural or remote areas, and you could start people right away. So instead of waiting in places where it'd be very difficult to organize the infrastructure, you could have basically a built-in pharmacy and treatment center from a machine. So we're going to try it out starting in 2 weeks with giving out hydromorphone pills, but I'm pretty keen that this could be used for many things we do, especially for marginalized and stigmatized problems. I finally want to, this is my last slide, just talking about how we have to integrate these kind of thoughts in what we do, and how we want to position ourselves as trying to make these bigger changes, and where we find ourselves on this ladder. So most of us start off as we want to be unbiased researchers and medical experts, and we do our research and then we hand it off to people who can do something with it, and then we go on to the next thing. And for many of us involved in drug use and people who are marginalized, you can't help when you get your research results, you want to do something about it. So a lot of us then go into translational kind of research and say, you know, can we use what we found with our epidemiologic research and work and try to see how it can function in the real world. And we go to the second stage. And then some of us can become advocates, so we at least want to join the discussion with community groups and activists that we can add our research or medical hat to give them some credibility. And then we can go to the activists, where we actually don't just support people who are already the advocates, but we become the leaders for change. And then you can get to the top layer, the shit disturber. Now, once you get up there, it's very difficult to come back down, so you got to be a bit careful because it gets a little slippery up there. But I think what we need to, the basic point of this is that as we talk about all our medical interventions, that we have to position ourselves as being spokespeople to make policy changes. And as I say, a lot of the work that we do and a lot of the frustration that we have is because there's policies in place that are very frustrating and making huge barriers to what we do. And I think we all have to ask ourselves where we can fit on this ladder to actually challenge policies and not just settle for the status quo and what we've been dealt. So that's all I have to say. Thank you.